Well, thank you very much. I would like to thank the Scientific Commission, especially the Secretary, for inviting me to speak about initial antibiotic treatment in the management of septic shock in the ER. It's a fairly short presentation. It might be very short, but I'll try to explain a few items with you. And, well, really ramming through open doors on the treatment of septic shock before filling and before norepinephrine. Even though Jean-Louis and Xavier may not quite agree, these are my potential conflicts of interest. Three things that I'll explain quickly, because apart from the last one, there aren't too many problems. When to start antibiotics, with what drug, and should you have single therapy or combo therapy? You'll see that the answers are fairly straightforward. When to start? As early as possible. You all know this paper that is now 8 years old by Kumar. On a large database in North America, he looked at survival as a fraction of time to treatment between the beginning of arterial hypotension and septic shock and the beginning of ABT. And in fact, what is clear is that survival is lower. It gradually decreases based on the time between the onset of hypertension and the start of ABT. The same results here, and the message is clear. Every hour that you lose when talking about septic shock, for each hour you waste, there's an 8% increase in mortality. So when to start? Immediately. In emergency. Jean-Louis and Xavier may not agree with it, but before filling, before norepinephrine, because that's an added 8% of mortality for every hour. We're talking about septic shock and not severe sepsis. If you're in severe sepsis or even infection, here data is slightly contradictory. I simply wanted to show you this study, which was published last year, 2 years ago, in Lancet Infectious Disease. You may be familiar with it. It's a pre-post study, and it's nosocomial sepsis. Compare two periods when they had an aggressive treatment, an aggressive approach in terms of ABT. Every time there was a suspicion, they started an ABT, and a more conservative approach. I don't think that this is what you should do, but just to show you how interesting it is and how you can find each and everything in literature. For conservative antibiotic therapy, what they did is that they waited for the result of the cultures that they did to start ABT. And here you can see that on the right-hand side table, the mean time between the start of blood culture and treatment. In the aggressive strategy, it was 20 hours, which is fairly long, and almost 48 hours in the conservative strategy. What did they find? If you look at mortality here, well, mortality for patients who were included. This is pre-post, it's not randomized. But with the conservative strategy, mortality was significantly lower than for the arm with patients with the aggressive strategy. It's not septic shock, it's not the ER, it's hospital-acquired, but it gives food for thought. The question behind all that is that you shouldn't give antibiotics to anyone. Here, the over-mortality is probably explained by extended durations that were not adapted. People who did not need antibiotics, so with adverse effects, and the rise of multi-resistant bacteria. So about the when, for the question at hand here is in emergency. Which drug? I would go back to what Paul Ehrlich said over 250 years ago: hit fast and strong. Going back to hitting strong, hitting fast, but also hitting strong with broad-spectrum antibiotics. With a nuance here in 2015, if you give broad-spectrum antibiotics, you need to be able to de-escalate. At a later stage, you need to adapt the ABT to the recovery and the suspected point of ingress and so on, if you haven't identified the germ. Why? Why? because we know that in septic shock and all infections, ABT, when it is inappropriate, leads to overmortality. This is a study published in Chest, Still Kumar, the king of data analysis, showing you that based on appropriate or inappropriate ABT, for all infections, positive or negative cultures, bacteremia or not, community-acquired or nosocomial, here depending on the location of the infection, when ABT is inappropriate, survival is clearly lower. Looking at all infections, survival is 60% in septic shock. If it's inappropriate, it's closer to 15%. That's why you need broad-spectrum antibiotics. Broad-spectrum doesn't mean ibuprofen for everyone. Let's agree on that. You shouldn't kill a fly with a bazooka. So you should give broad-spectrum antibiotics, but depending on the locus of infection, there are guidelines in all scientific societies. Give this or that antibiotic based on the locus of the infection. You don't give a third-generation cephalosporin for a suspected meningitis or clavulanic acid for intra-abdominal infection, or third-generation cephalosporin for urinary infections. Cephalosporins or augmentin and clavulanic acid associated in intracellular. Just drawing your attention to some patients you may encounter, still talking about septic shock in the ER. And when you discuss it with emergency doctors, sometimes they face patients who have risk factors. They may have ESBLs. I told you broad-spectrum ABT, that's third-generation cephalosporin, but in some patients that you need to be aware of who have risk factors for ESBL enterobacteria colonization, for these patients, in some cases, you may have to prescribe carbapenem. It's not a majority, but it may happen. I discussed this with an ER doctor in La Pitié. She said that every once in a while, not once a month, but every once in a while, or once every 6 months, she faces a patient with community-acquired sepsis with a risk factor for ESBL. So you know the risk factors. All those who have met caregivers who hospitalized before or not, and who had invasive procedures or who received antibiotics. And another category, this is now a 4-year-old study, but it's still topical. Another category, people who are coming back from foreign travel to a country with endemic ESBL. You may know this study, but it's appalling. People who go on tourist trips, they come back and they get a swab test when they come back, looking at whether they carry ESBLs. And when you come back from India, it's a small group, but you have 9 risks. The risk is 9 to 10 of having ESBL. Back from Asia, 1 to 3. The odds are 1 to 3. It's not yet included in the guidelines, but coming back from a country where ESBLs are endemic, you may not have been hospitalized there, but simply coming back as a tourist from these countries is a risk factor. Coming back from India, that's clearly a risk to carry ESBLs. That doesn't mean that when you come back from India and you have septic shock, you should use meropenem or other strong antibiotics, but that should beg the question. These particularly severe patients who may have another risk factor, well, you may further broaden the spectrum than third-generation cephalosporin with meropenem. And discussing it with ER doctors, it does happen sometimes that on community-acquired sepsis that you need to have broad-spectrum beta-lactamine like carbapenem. But don't get me wrong, you shouldn't give carbapenem to everyone. Quite the contrary. But it should be sensible. Maybe we should need decision trees for this type of treatment. a word about specific populations, just to remind you of the guidelines from IDSA on the use of antibiotics on community-acquired sepsis in hematological patients who are neutropenic because of cancer. In emergency, broad-spectrum beta-lactamine. This is a specific case with an aminoglycoside or fluoroquinolone if it's complicated, and vancomycin is not recommended as first-line treatment. It should be discussed in case of central venous catheter infection, cutaneous infection, skin and soft tissue, pneumonia or hemodynamic instability. That's mostly for North America, at least for pneumonia, for vancomycin, because in France, resistant Staphylococcus aureus pneumonias are very rare in France. A word on the use of antifungals to summarize the literature. Is it relevant to include antifungals in sepsis, severe sepsis or septic shock in the ER? No benefit for community patients. We're wondering for hospital-acquired infections, but this is not an issue for community patients. For neutropenic patients with mask scores below 21, this is an oncology score for patients who have the highest risk. In the guidelines by IDSA, antifungal treatment only if the patient still has a fever after 4 to 7 days. That's what we usually do in hematological ICU. Same for hematological patients. So no indication for antifungals, only antibacterials. These are broad-spectrum antibiotics, third-generation cephalosporin. One word, if you give antibiotics, Xavier and Jean-Louis talked about filling volume, adapting the filling volume. Well, for antibiotics, it's the same thing. Don't forget that if you look at the kinetics here, from the pharmacokinetics of an antibiotic over time, if you give a dose, if the MIC of the germ is here, well, you need to wait for 3 doses before the antibiotic is effective. If you give antibiotics to a patient, you need to reach the minimum inhibitory dose very quickly. You need to double the posology. If you want to give 1 gram of cefotaxime, you should double the dose. The same thing for ampicillin and others. And don't forget that the loading dose helps you achieve a quick, effective dose to be above the MIC, and we know that these pharmacokinetic, pharmacodynamic criteria are very important for the bactericidal activity in our patients. One last word, which is probably the most important: should you give a single therapy or an association of antibiotics? And the data in the literature are not clear, rather in favor of twin therapy, but the data are still fragile. Why talking about twin therapy in septic shock? Well, first, and this is probably the main reason, if you give twin therapy, you increase the probability of covering the germ responsible for the infection. That's mostly the relevance of twin therapy. There's another benefit. Based on the combo that you use, you may have more rapid bactericidal activity, apart from having an additive or synergistic antimicrobial effect. For some compounds we'll see with macrolides, there's a potential beneficial immunomodulatory effect on severe community patients and prevents the emergence of resistant superinfections. It's true for some, but there are some for which, in terms of efficacy, there is an issue. For bactericidal activity, it's not a recent paper, but it's still topical. Authors showed it's an experimental model in neutropenic rats when challenged with Pseudomonas aeruginosa peritonitis. When they are given a combo therapy, there is much better survival than when they're given single therapy of one of the molecules used in the combo therapy. And so the idea for these authors, what is true in petri dishes and is also probably true in animals, there's faster bactericidal activity and so better survival. Does that increase the coverage of germs responsible for infections? Yes, but mostly for hospital-acquired germs. This is a paper by Martinez published in AAC 4 years ago, 2010, in which they look at the percentage of coverage by a single therapy. Here, all combo therapy based on the type of germ. For enterobacteria, mostly enterobacteria, gram-negative bacillus, monotherapy does as well as combo, but for hospital-acquired germs, bed, ESBL, Pseudomonas aeruginosa, or others, this is where with the combo you can really cover the holes in the coverage of monotherapy. There's a greater percentage of germs covered by combo therapy in terms of microbiological coverage than monotherapy, and this is significant. Does that result in a clinical benefit for the patient? It's a bit more complicated. There is this paper that you may know, still by Kumar, published in 2010, where over a large database of septic shock, over 2,000 septic shocks, he assessed the effect of monotherapy versus combo therapy. And here I would say that in this work, all patients had one active antibiotic versus the germ that was recovered and responsible for the infection. And in 2010, he said that when you give a combined antibiotic, survival, this is the curve at the top, survival is better than effective single therapy for the germ responsible for the infection. So combo therapy saves lives. That's what he said. But this is a database analysis. Despite all the matching, you can always make mistakes and conclude on effective combo therapies when there's no such effect. And you'll see in the literature that there are data that go against combo therapy. For instance, this paper published in AAC 2 years ago, where the authors in cases of Pseudomonas aeruginosa bacteremia, they compared effective monotherapy versus effective combo therapy. The curves speak for themselves. About 100 patients, no difference in terms of mortality. This other paper by Carmen Peña, published in CID last year, here Pseudomonas aeruginosa bacteremia, where she compared 3 groups. Patients with inadequate initial antibiotic therapy, and then the dotted black curve here, adequate single drug therapy, and patients, the full line patients who receive adequate combination therapy. When you have adequate combination therapy, when it's inadequate, you have more mortality, but when single drug therapy is adequate, there's no more deaths. There aren't more deaths than when you have adequate combination therapy. And there are a lot of such examples in the literature, and the author, the speaker that I'm replacing, Frank BRUNKHORST, published a study that is one of the only ones in the literature comparing monotherapy and twin therapy. There are a few problems because it's a very broad spectrum antibiotic therapy. Meropenem on the one hand versus meropenem and moxifloxacin with severe sepsis patients who are not colonized by multi-resistant germs. And you can see that in this study, which was randomized, over 500 patients, that's quite a bit, and at the end of the day, single drug therapy does as well as combo. And therefore, we're between Kumar, who said that if you don't have combo therapy, you are killers, and randomized trials and cohort studies that show that single drug does better. For community-acquired pneumonia, it's a bit specific because combo therapy on septic shock is usually with an aminoside, but for community-acquired pneumonia, it's a beta-lactamine or fluoroquinolone or intracellular agents. In this study from Critical Care published by Adri, he took about 1,000 patients with community-acquired pneumonia requiring ICU admission. What he found, very quickly because we're running late, initial adequate antibiotic therapy was associated with improved survival, and if it's inadequate, worse survival. Having dual therapy was associated with more frequent adequate treatment, but if you look at the difference in mortality between dual and monotherapy, there was no difference. And this is recent work from 2013. This calls into question the association here. Monotherapy was mostly beta-lactamine and the association of beta-lactamine and macrolides. So it seems to call guidelines into question what we are told to do in the ER for severe pneumonia, beta-lactamines with macrolides or fluoroquinolones. And this is because dual therapy seems to work in studies. Here, this was the paper in Critical Care Medicine. It only seems to work in patients in shock with the idea of immunomodulation by macrolides or fluoroquinolones. And just to show you this work, if you look at patients without shock, twin therapy or single therapy, community-acquired pneumonia, beta-lactamine plus macrolide, it does as well. But for shock patients, the combo yields less mortality than monotherapy. So mono or combo, to conclude. Mono or association for severe septic shock, although there are data that are a bit jarring. It seems that combo therapy is still the dogma, mostly because you increase the probability of covering the responsible pathogen, and even beta-lactamine and aminoglycosides or aminosides is active. Even the aminoglycoside is active even if the beta-lactamine isn't. So for septic shock, if it's pneumonia with shock, macrolide or fluoroquinolone. But what's important is to de-escalate, and monotherapy after 48 or 72 hours, even in episodes of bacteremia or Pseudomonas aeruginosa pneumonia. Here, this is nosocomial infections. This does as well as dual therapy. So I know that this may seem shocking to a few, but single therapy after a couple of days of twin therapy. So this is something that you know. You should act fast. Asked beta-lactamine because bactericidal activity is quicker, broad spectrum at best when possible, and mostly third-generation cephalosporins. We know that there are broad-spectrum antibiotics. When I talk broad-spectrum antibiotics, when I say that, that's third-generation cephalosporins depending on the locus of the infection. You know that better than me. Association for the first 48 to 72 hours outside of specific germs like Legionnaire's disease. No need for antifungals. And to conclude, well, that's it. That's all I had. Thank you. Well, thank you.